Hello, and thank you for viewing the Melanoma Research Foundation's webinar, Treating Uveal Melanoma During COVID-19, an update on current clinical trials and plans for the future. My name is Shelby Munir, Director of Education at the Melanoma Research Foundation. I'd now like to introduce our speakers, Dr. Marlana Orloff and Dr. Sapna Patel. Dr. Orloff is an Assistant Professor of Medicine and a Medical Oncologist at Thomas Jefferson University Hospital, Sidney Kimmel Cancer Center in Philadelphia. Dr. Patel is a medical oncologist and director of the Uveal Melanoma Program, Online Media, and Fellowship Program for Melanoma Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston. Please take a moment to read both full bios on the left-hand side of your screen. Dr. Orloff, I'd like to thank you for being here, and I'll now hand it over to you.
All right. Thank you, Shelby, and welcome, everybody. Thanks for tuning in to this webinar. So myself and Dr. Patel today just want to give a kind of unique presentation talking about treating uveal melanoma during this global pandemic. So certainly COVID-19 has had an impact on just about everything, and its impact on cancer and specifically uveal melanoma is no different. In speaking with fellow doctors and patients, you know, we've certainly seen it impact the community in a variety of different ways. Some patients and some physicians have seen a delay in primary diagnosis and treatment, and that's simply because, as many of you know, the presenting symptoms of uveal melanoma are often vision changes or no symptoms at all, and patients are just going for a routine eye exam. Some of that has been delayed just because of access to care or fear of just going to the doctor. There has been some difficulty with routine ophthalmology follow-up. This may be due to travel restrictions. Certainly, if your ocular oncologist is not exactly where you live, something as simple as, you know, getting a flight has been difficult. And unlike, you know, some areas of medicine where you can have the visit over telehealth, getting a comprehensive eye exam is not really made for telehealth. There certainly has also been a decreased access to surveillance imaging. So this is for after patients are diagnosed and they're getting their, you know, every 3, 6, 12 months CAT scans and MRIs. Some patients just simply, you know, had a fear of getting out to these radiology centers. And actually the radiology centers themselves, the number of which were closed or were limiting the scanning to just emergency situations. In general, from what is being reported, there's been a halting of a lot of the adjuvant trials nationwide. So again, just a reminder, adjuvant trials are patients who've been diagnosed with a primary eye tumor, and the adjuvant trials were trials in searching for drugs to try to prevent the disease from coming back. So because these drugs and treatments were actively treating the cancer, a lot of them were kind of deprioritized to allow for other trials to continue. Even though metastatic trials are very important as they're treating active disease, there has been a variable halting of these trials nationwide. And this is dependent on the clinics and the hospitals where they're being carried out, some because of resource issues, resource allocation, and other reasons. And then there's also been just difficult with access to standard of care for metastatic disease. So outside of a clinical trial, again, patients may have been hitting barriers regarding travel restrictions, and just the general change to cancer care delivery on a whole. So I want to mention, though, that at least at Jefferson, and I know a number of other centers that treat uveal melanoma around the country, we've really tried not to stop. Certainly at Jefferson, therapeutic melanoma clinical trials really never stopped. We were fortunate enough to have a system in place, you know, that allowed us to really continue without much interruption. So this is just a picture of our Bodina Infusion Center, which is where a lot of our phase 1 clinical trials are carried out. And there was actually one day where the only patients coming there for treatment were uveal melanoma patients there for phase 1 and 2 treatments. And then on the right-hand side, you see actually a first patient who was just treated on a clinical trial investigating drug targeting PRAME, who was just enrolled on May 18th. So you see us there wearing our masks, taking special precaution, but again, we've really tried not to stop clinical trial enrollment and treatment of our patients. But it's really taken a lot of work by both the staff, the nurses, the physicians, and everyone to keep things going. So generally what we do today is talk about some of the current treatment options, and we've broken them down into the different categories of liver-directed therapy, immunotherapy, and targeted therapy. I'm going to give a general summary of these approaches. I'll talk a little specifically about some of the data with these approaches, talk a little bit about specifically what we have ongoing at Jefferson, and then a bit about what are some clinical trials and approaches hopefully coming down the pike. And then I'm going to turn it over to Dr. Patel, where she'll again go through these general groups of treatments and talk specifically about what's going on at MD Anderson. So the first type of approach to treatment that we're going to talk about is liver-directed therapy. So for those who haven't heard me speak, or Dr. Eshelman or some of the other interventional radiologists that often talk about this topic, I want to just give a brief overview of what liver-directed therapy is. So as many of you know, uveal melanoma, for unique reasons that we haven't completely figured out yet, often metastasizes to the liver. And in many cases, the liver disease burden becomes a life-limiting or life-threatening situation in uveal melanoma. So targeting the liver is very important. Liver-directed therapy involves threading a catheter up through the femoral artery in the groin, all the way up to the liver that you can, and that's explained here on the diagram. And then through this catheter, we're able to deliver different types of medicines, or actually tiny radioactive beads that directly hit the tumor. In some cases, we also cut off the blood supply of the artery, so an embolization procedure is done, which can kind of choke the tumor. And the reason that we can do this and it's safe is because the liver actually gets its blood supply from two different places, the hepatic artery and the portal vein, and the tumors preferentially get their blood supply from the hepatic artery. The nice thing about this approach as well is that we can give very high doses of whatever agent we're using because it's really being collected and staying in the liver. So in regards to, say, chemotherapy, we can give very high doses of chemotherapy this way, much higher than we would be able to give through the IV without hitting a lot of side effects. So types of liver-directed treatment, there's something called immunoembolization, where we administer a small amount of immunotherapy, something called GNCSF and IL-2, and this is also followed by closing the hepatic artery. Radioactive microspheres, often used SIR spheres. These are tiny, tiny radioactive beads that also kind of clog up the artery and then emit local radiation in the tumor. Chemoembolization, often the drug used is BCNU. Chemoembolization with something called drug-eluting beads, which are tiny beads that also block off the artery and then emit chemotherapy, something called DebDox or Debiri. Hepatic artery infusion can be an option. There's a drug called photomustine. It's not really used in the States. It's used in Europe. Bland embolization. A treatment approach called percutaneous hepatic perfusion, or PHB, with a drug called melphalan. This is ongoing in a clinical trial called the FOCUS trial, or DELCAS. Isolated hepatic perfusion, which is a similar approach, but instead of a catheter system that's used to isolate the chemotherapy in the liver, it's actually a surgical approach. And then listed here, I also have kind of liver-directed but more localized treatments, and that's surgical resection. Often patients will ask about this, and at least at Jefferson, we really want to make sure if someone is a candidate for surgical resection, there's really only one tumor, and they have kind of proved ones aren't going to pop up soon. And that's because you don't want to go through a big surgery to resect and then something new grow back a month or two later. So surgical resection is actually used pretty rare, at least in our practice, just because the concern that some other lesions can pop up later. Whereas liver-directed therapy with those other approaches can kind of treat the whole liver and sometimes even lesions that you may not see on MRI. Ablation is a less invasive, almost approach similar to surgical resection in that you're really just targeting one lesion, the most common approach being microwave ablation, where the interventional radiology doctors can stick a needle in the tumor and actually burn the tumor. Again, this is only used for a select population of patients. So currently available at Jefferson, we have ongoing a number of clinical trials that are actually combining liver-directed therapy with systemic immunotherapy, so immunoembolization, plus the drugs ipilimumab or Yervoy and nivolumab, which is Opdivo, which are two immune checkpoint inhibitors. Also radioactive microspheres followed by that immunotherapy, and then coming soon, we're going to have a protocol for chemoembolization with higher doses of BCNU. In addition to the clinical trials, we still are offering standard care, immunoembolization, radioactive microspheres, chemoembolization, surgical resection, and ablation. I do want to just relate one study that we recently published, and this is a very interesting paper that actually is an overview of really the last 50 years of treating metastatic uveal melanoma patients at Jefferson. And what we did was retrospectively looked at 3 different cohorts. There was cohort 1, cohort 2, and cohort 3. And in many ways, the cohorts defined by time, as you can see, were also defined by which first therapy standard of care was being used at the time. So cohort 1, which was really the 70s through the 90s, was really early DTIC, or an old chemotherapy-based treatment that was offered to uveal melanoma patients, followed by cohort 2, which is the introduction of really liver-directed therapy as often our first choice in the treatment of our patients, followed by cohort 3, which is really liver-directed therapy plus some of these novel new clinical trials that have recently come out. And what you can see here is that the survival from diagnosis of liver metastasis to death has greatly improved over the years. Still not good enough, but it's gone from about 5.3 months to 13.6 months to almost 18 months now in cohort 3. Patients or other people will often ask, but the MRIs in 2010 were probably better than the MRIs in 1970, so maybe you're just picking up lesions smaller earlier, and that's why it looks like patients are living longer. But in fact, we also looked at time from eye diagnosis to death, and these numbers kind of still stayed true, meaning that we think we are impacting survival in patients. And this is a little bit different than a publication that was reported that's up there in the blue box that talked about, that survival times have not really improved and the median survival being poor, and this was published in 2018. We found something different. So here, this is a query of clinicaltrials.gov. Just recently, these are some current liver-directed therapy clinical trials for metastatic uveal melanoma. There's the percutaneous hepatic perfusion. There's the 2 trials that I mentioned, or combination trials that are ongoing at Jefferson and a number of other sites. And then there's PV10 chemoablation, which actually Dr. Patel will talk about in her section. So the next section I want to talk about, our next approach, is immunotherapy. So immunotherapy is certainly a hot topic. I'm sure a number of you watching have heard about immunotherapy. Immune checkpoint inhibitors are kind of the most common therapy when we talk about immunotherapy. And they're the drugs, I'm not going to go into defining them today, but they're the drugs that really take the brake off the immune system and allow the immune system to fight against cancer. And that's the Yervoys, which is ipilimumab, which are CTLA-4 antibodies, and then the PD-1 antibodies most often used in melanoma are pembrolizumab or Keytruda, and Opdivo, which is nivolumab. Unfortunately, the response rates are not as good in uveal melanoma when compared to what's seen in cutaneous melanoma. We do see some responses, and Dr. Patel will be talking a little bit more than that, but we know that we could do better. So there's really a big effort in uveal melanoma to open and explore drugs on clinical trials that are unique approaches to immunotherapy. So really understanding, say, why the drugs like Yervoy, Opdivo, and Keytruda don't work, and coming up with a new strategy. So the clinical trials that are ongoing right now in this space are what I consider to be called T-cell redirectors that we'll talk about, adoptive T-cell therapy, which Dr. Patel will talk more about. And then there's other targets and checkpoints beyond CTLA-4 and PD-1, something called TIM-3, LAG-3, CD47, and certainly others. So what is uveal melanoma resistance to standard immune checkpoint immunotherapy? And again, the important thing to remember with the immune checkpoints is, again, it's really using your body's own immune system to go after the cancer. The problem is that uveal melanoma is pretty good at hiding, and it has what's called a low tumor mutational burden. And we know that the more mutations a tumor has, the more foreign it looks to your immune system. And uveal melanoma is known for having a low tumor mutational burden. It doesn't have something called PD-L1 expression, which again is really a marker that the immune system is able to recognize it. And then again, going back to the site that's most common in metastasis, which is the liver, we think that there's something special about the liver, and it's that an immune privileged site, or that the immune system has a hard time getting into the liver and destroying things that shouldn't be there. So what do you do? How can you overcome resistance to immunotherapy in uveal melanoma? Very simply, you can make the tumor more of a target to the immune system, so you can do something to the tumor to make it look more foreign, or you can make the immune system go after the target on the tumor. So really drive the immune system over to something that already exists on the tumor. And these are, in my mind, these are kind of just real two simple ways of trying to overcome that initial resistance. So when we talk about number two and really just pulling the immune system over to the cancer, we are exploring that. And there is a kind of class of drugs now called ImmTACs, or immune mobilizing monoclonal T-cell receptors against cancer. And how I explain this drug is it's really almost like a strong magnet on both sides. And on one end, the magnet binds to CD3 on the T cell, and on the other end, it binds to the cancer cell, because there's little bits of things that are actually presented on the cancer cell surface. And this two-way magnet really just, again, pulls the immune cell over to the cancer, and they engage in it, and it's killed. And you can see that in this diagram in steps 1, 2, 3, and 4. So you may have heard about a drug called IMC-GP100, and this is a drug that's been furthest tested in uveal melanoma. And GP100 is something, again, that's presented on the surface of the cancer cell, and these clinical trials have been ongoing and have been showing really positive results in uveal melanoma. The nice thing about this technology and this platform is that you could really design this ImmTAC to go after different types of targets on the cancer cell. So if for some reason GP100 isn't on the surface or the drug stops working, you can actually look to other targets. So other targets being explored are something called NY-EOS, MAGE-3, and then MAGE, and then the most recent one is something called PRAME, which does have some data in uveal melanoma. And so this is the new trial that we've recently opened. Unlike GP100, where it's thought to really be common on most, if not all, uveal melanomas, these other targets, you need to prove the target's there, because if the target isn't there, then these drugs won't work. So what we can do is we do a small biopsy, and then we can send the tumor off for testing of all these different targets to see if these drugs are an option. I will comment, though, that there's still a need to have HLA-A201, so it's a special, we call immune type or tissue type. And that's because, and you can see in this diagram, that blue linker, the ImmTAC or the magnet, needs to bind with HLA on the cancer cell. That's basically the way that the cancer cell kind of puts a little bit of whatever target on its surface, and it kind of needs to fit like a lock and key, and these drugs are developed for that special HLA type because it's the most common HLA type in the patient population. About 50% of patients will have that. So you still do need to have the HLA type A201. So these are some immunotherapy clinical trials for uveal melanoma. The top three are exploring those ImmTACs that I mentioned. There's a number of adoptive T-cell trials. There's some other novel immune checkpoint trials, so looking at LAG3 and TIM3 and CD47. And then there's a couple of other kind of gene virus trials that are ongoing. So not all of these trials are specifically unique to uveal melanoma. They may be trials that are looking at treating a bunch of different cancers, but they will include uveal melanoma, and there's some at least thought that some of these approaches may be useful for treatment of uveal melanoma. Lastly, I'll talk about targeted therapy. GNAQ and GNA11 are mutations that are found in about 85 cases of uveal melanoma. But unlike things like BRAF in skin melanoma, where it's easily targetable and there's drugs to target that mutation, we haven't really been successful in targeting GNAQ and GNA11 directly yet. There's also BAP1 mutations and other mutations like SF3B1 and IFAX. Again, we haven't really been successful yet in targeting these specific mutations. So there's a lot of drugs that are being explored that may directly or more likely indirectly target known mutations or downstream parts of this very complicated pathway that you see over here, or be used to modifying how genetic material is processed. And again, it's not as simple as just, finding a drug and a target, as you can see again by the diagram on the right, but there's lots of different ways that the cell communicates. And GNAQ and GNA11 happen to be kind of right at the top of that cell signaling pathway. So There have been many attempts to uveal melanoma to target these targets. And again, you can see GNAQ, GNA11 circled at the top, and a lot of the efforts have been to try to target things downstream to kind of block that last step, at least, the cell proliferation and survival. So there have been efforts to target MEK and PI3 kinase, RAS, MEK and something called AKT, PKC inhibition, and MEK inhibition has had the most data. But again, even though there was some early excitement about the MEK inhibitors in the first phase 2 trial, unfortunately, subsequent trials haven't reproduced that. However, and Dr. Patel will be talking about this, that there's some thought that maybe an alternative schedule or intermittent dosing of MEK inhibitor may actually be beneficial in this patient population. So I do want to talk about one PKC inhibitor. On the previous slide, there was another PKC inhibitor. This one's different, called IDE196, also previously called LXS196, that again has now had the most data in uveal melanoma. So the phase 1 dose escalation trial actually recently completed accrual, and data is maturing. We do think that there's going to be a dose escalation in combination with MEK to be open by mid-year. On the right-hand side, you can see we call a waterfall plot that was actually presented at AACR meeting back in 2019, and this is when the drug was called LXS196. And if the bars are going up, that's tumors that grew, and if there's bars going down, that's tumors that shrunk. So you can see on the right-hand side, there's a number of bars that are actually going down, and that one blue bar is going pretty far down. And there actually was a patient who ultimately had a complete response, and he was remaining on therapy still as of March 24th, 2020. So again, this looked pretty promising. Phase 1 data is maturing, and hopefully the dose escalation will open sometime this year. So see some of the current targeted therapy trials for MUM, the intermittent siumetinib that Dr. Patel will talk about, PKC, which I just discussed. There's a RIB trial, BET inhibitor trial, and then a FAC plus MEK trial, like also that Dr. Patel will be discussing. In no way are any of these yellow charts from clinicaltrials.gov fully exhaustive. There may be trials out there. I just want to mention that there may be trials out there that for some reason I didn't capture. But again, this is a good summary of what's out there. So look ahead. I do want to mention that we at Jefferson have a number of trials that we're hoping to start in the fall. Again, that PKC inhibitor plus MEK. We'll also be opening a FAC inhibitor plus MEK. There's a PAC1 inhibitor with entrectinib that will hopefully be opening. And these are all kind of targeted therapies. The chemoembolization with varying doses of BCNU to be open. And then there's a couple trials that we consider under consideration. So we'll be looking at intrahepatic here mismatched NK cells. So NK cells, also called natural killer cells, are kind of like a hunt and destroy type immune cell. And we're looking into actually infusing those directly into the liver. And this is kind of like a radiation trial, something called Rhenium-188. So these are all things that we're hoping to open, to keep a lookout for. Obviously, always subject to change. There's always trials that you hope to open and for some reason or other don't open, but I would keep an eye out for those. So I just want to end my part by saying reach out. We've had a number of patients who have called us with concerns because they felt like perhaps their care has been impacted by COVID-19. If you feel like your care has been impacted, reach out to your doctor and discuss. We are here, we are working. So telehealth is a way to connect, even if you just want to chat, even if you don't have an active problem, but you felt like you haven't seen a doctor to touch base with. The fortunate thing about telehealth is that before all of this, we actually couldn't really easily do telehealth with patients in states for which we weren't licensed. So me personally in PA, I could only really communicate via telehealth with people in PA, New Jersey, and Delaware because those are the license I held. Dr. Patel, Texas is a big state, so maybe she was only licensed in Texas. But fortunately, because of COVID-19, things have opened up. So now I can actually do telehealth with patients in all 50 states. And I would say just over the last couple of weeks, I probably have telehealth with patients in at least half of those states. As things open back up, there may be more options available, and every institution is going to be different in how things open up. certainly, again, because the states are all different and how, things are opening up individually. And then clinical trials may take a while to fully reopen nationwide, but again, I encourage you to keep talking to your doctors, and at least, I know at Jefferson we're trying our best to keep our patients informed about what's going on, but again, just, reach out if you have any concerns. All right, I wish this webinar could have been in person at the patient and caregiver meeting. It's always one of my most favorite meetings of the year, but hopefully I will see you all in November. And then I just want to end my part with turning it over to Dr. Patel. So Dr. Patel, take it away.
Thank you, Dr. Orloff. I'm Sapna Patel, as Shelby introduced at the beginning, and I am a medical oncologist at MD Anderson. So in a very similar fashion, I will take you through our options in the same series that we're doing currently at MD Anderson. We'll start with liver-directed therapy. And our current clinical trial option for liver-directed therapy is intratumoral or intralesional PV10. PV10 is also known as rose Bengal, owing to its bright red or pink color. You can see up there in the circle on the left the color of the drug in the vial. It's a tumor irritant, so once it's injected, it causes tumor disruption and cell death, and subsequent release of proteins that we call tumor antigens. And these antigens have the potential of generating an immune response. On the right side, you see a broom-like multi-pronged catheter, and it's entering a dark gray uveal melanoma liver tumor. And then on the far right of that radiology series, you see it's then depositing the white opaque PV10 drug. This is kind of a unique feature of PV10, that it's radio-opaque, so the interventional radiologist can actually see the delivery and ensure that it's staying inside the tumor. Below that, you'll see that there is a waterfall plot, and that waterfall plot, as Dr. Orloff explained, essentially tells you about tumor change. And so this is referring only to the injected tumors, but you can see there's a number of patients in whom the injection did decrease the overall size of the tumor. For now, this study is recruiting patients who have received immune checkpoint inhibitors, so Opdivo, Keytruda, or Yervoy, something like that, and who have progressed on that treatment. So the beauty of this study is you're actually allowed to continue immune checkpoint inhibitor in the background while we add PV10 to the treatment. So we're essentially allowing you to continue. We just want to see if boosting the response with PV10 can help. In addition to clinical trial liver-directed therapy, we can also perform standard of care maneuvers such as ablations or embolizations. And like Dr. Orloff talked about, there's a number of standard approaches. One that we have recently started doing a little bit more frequently is something called irreversible electroporation. That's on the left side of your screen in the circle. This is a technique where a probe enters the tumor through the skin typically, and then an impulse is transmitted down to disrupt the tumor membrane. This disruption is irreversible, as the name kind of implies. It means that the tumor cell wall cannot be repaired. And then this leads to a potential persistent anti-tumor effect. What you see in that top row are a couple of MRIs where the white arrow is pointing to some tumor. In the second row, you see 24 hours after an irreversible electroporation. On the left, you see that widening ablation zone. And in the middle, in that second row, what it's trying to point to, I know the slide is small and kind of dark, is another series of that MRI. On the right-hand side of the second row, you see this thickened white rim with the darkened central area. Again, this is telling you about the tumor border and the ablation zone. The third row is actually 1 month, 30 days after treatment. And you can see that the ablation zones are coming down in the middle. What you're supposed to see is that white hyper-intense dot is getting smaller. This is the tumor. On the far right, you see the ablation zone is thinning, the rim of it. And then at the bottom, the last row is 120 days after treatment. And so, approximately 4 months later, the ablation zone is entirely resolved, and you don't see any regrowth of tumor. And so It's an interesting approach, again, for patients in whom liver-directed treatment might be an option. And radioembolization, I thought it would be interesting to show you guys slides on the right-hand side of a patient I saw just this week. And so he had a quite large dominant tumor on the left-hand side radiology. You see this is a CT scan. He had this in March. It was about the size of an orange, a small orange. And now we treated that with radioembolization using yttrium-90, Y90, these beads, and approximately 2 months later, there's more than half reduction in that tumor. You can see some of the normal gray is filling back in, but that tumor is a little deceiving on the right-hand side. It certainly still is there. It's not quite as small as it looks, maybe on this slide. But it has a nice reduction, and in my experience, radioembolization plays a role when there's a dominant tumor such as this, or when there's a diffuse, maybe there's small volume tumors. You might have heard the phrase too numerous to count, too many tumors to count. And the reason is these beads that get put in by the interventional radiologist through that, through the groin to the hepatic artery circulation, as Dr. Orloff explained, these beads are so tiny, and the beads are coated with the radiation. They permeate down to the smallest blood vessel level, the capillaries, and that's where they do their clogging effect and then release the Y90. And so if you have too many tumors to count, shoving these beads down into that small capillary bed makes a lot of sense to do their release of radiation. Now on to immunotherapy. Immunotherapy comes in a few different flavors. We recently completed and have reported our final results of the U.S. trial of ipilimumab and nivolumab for metastatic uveal melanoma. This would be considered standard of care treatment. You don't need to access these drugs on a clinical trial. They were approved several years ago for metastatic skin melanoma. And we now know that the response rates and clinical outcomes are different in this population compared to skin melanoma using this treatment. We had 6 out of 33 responses using criteria known as RECIST 1.1 for a response rate of 18%. And we're still confirming if that yellow patient on the far right of the waterfall plot is a complete response in her non-target lesions. On the right-hand side, you can see something called a spider plot. And essentially what this shows is there's no phenomenon known as pseudo-progression with this regimen. If the treatment is beneficial, the benefit is demonstrated early on. And similarly, here's something called a swimmer's plot of the clinical benefit group. It shows the median duration of disease control in this group is 18 months. And so in our data set, if ipi-nivo was beneficial, it ranged in benefit from under a year, around 10 months, to almost more than 4 years here. We have an ongoing clinical trial at MD Anderson that was recently presented a few weeks ago at the annual AACR meeting. It used something called a porcupine inhibitor of the Wnt pathway in combination with an anti-PD-L1 antibody known as spartalizumab. This study actually required that all patients enter having progressed on prior immunotherapy. And so what I marked on the left waterfall plot with the small letters SD are the 5 uveal melanoma patients that entered this study. And, as Dr. Orloff would agree, it's quite interesting to see that all 5 uveal melanoma patients who had progressed on prior anti-PD-1 therapy had stable disease with this treatment regimen. So it's suggesting that the porcupine inhibitor might have been helping to revive an immune response in these 5 patients. This study is ongoing. It continues to enroll patients who are refractory to immunotherapy and who do not have bone metastasis, as that can be a complication of Wnt inhibition. Another form of immunotherapy involves using autologous or self-donated T cells. And there's essentially 2 trials using self-T cells, TIL and ECT. Tumor-infiltrating lymphocytes, or TIL therapy, requires the surgical removal of a tumor, or in some cases, maybe multiple biopsies of a tumor. And we retrieve, what you see there is these fresh live T cells. The tumor is cut into small fragments, it's put in a multi-well plate, and then live T cells are kept alive. So essentially, out of the body, the tissue cannot die. The tumor cannot die because then the T cells in that tumor are dying, and so you have to do this quite rapidly, typically within 4 hours, put the retrieved specimen in culture. The cells are cultured with a variety of signals, as you can see here, signals 1, 2, and 3, and this generates millions of live active T cells. It takes about 2 weeks to know if the culture will be successful, and on the right-hand side, what you can see is we have successfully generated TIL from both metastatic tumors using this 3-signal method with the 100% success rate in 22 cases, and also from enucleations or eye removal of primary uveal melanoma in 90% of our 10 cases where the patients opted to have their eye removed, and we use that opportunity to grow TIL as a backup option should they need it. It's interesting. We haven't treated too many patients with this method, so this is just showing you the growth of the TIL, but the next part is obviously to treat patients with their TIL that have grown, because there's a pause here between removing your T cells, growing your T cells, and waiting for an opening on the trial. Most patients go on to other treatment and they don't immediately receive their T cells after a harvest. Endogenous cell therapy, ECT, is similar but different. We take blood essentially and go fishing around for T cells that match a known protein of interest. And in this case, we have a couple of trials, one targeting SLC45A2 and one targeting PRAME. Once these T cells are identified and isolated, they can be expanded again to several million and billion active T cells against the target. And the 2 trials generating T cells in this fashion, one against the marker SLC45A2 and one against PRAME, are also HLA restricted, as Dr. Orloff mentioned, with the redirecting T cell therapies. So it's restricted to HLA A0201, but also A2402 patients are eligible for the SLC45A2 study. We have had one patient actually who had both, because you get one HLA from your mother and one HLA from your father. And so you just need one HLA to be A0201 to qualify for these trials. We actually had a patient who had one allele of A0201 from one parent and then one allele of 2402 from the other parent. And in the laboratory, this makes for an interesting discussion because you use different pulsed peptides based on the HLA marker. And so it's a little bit of a debate, do we pulse the HLA A02 allele, or do we pulse the 2402? And my thought was, let's pulse both and use the better batch, but of course that's an expensive option that I'm suggesting. So the SLC45A2, just to reiterate, is restricted to A0201, but it also takes 2402. So as Dr. Orloff mentioned, A0201 is the most common finding, but there's a good portion of other populations in the world that have A2402. During the COVID-19 pandemic, and really due to the great laboratory personnel and resources needed to keep these live T cells in culture, all of these T cell options that I just described, TIL and ECT, are on hold. Finally, moving on to targeted therapy, Orloff mentioned we're finishing a trial using on and off dosing schedule of the MEK inhibitor known as selumetinib. And this is based on some mouse work that I'm showing you on the left here using BRAF inhibitors in skin melanoma. And this showed how continuous dosing in the top row of targeted therapy possibly led to earlier tumor growth and earlier tumor resistance compared to the on-off dosing schedule that you see on the bottom. And the on-off dosing is really dependent on a drug's half-life, so how many days you take it and how many days you hold it. The idea is if you do an on-off dosing, you can not only use higher doses than would be tolerable by a human when you use continuous doses, but also you would show what this panel on the left is showing you on the bottom, that you could forestall the development of resistance. On the left-hand side, they actually use the same dosing, but in our clinical trials, we're actually using higher dosing than were used in the previous selumetinib trials, really because at those known dosing levels, the results were not necessarily reproduced and durable, as Dr. Orloff mentioned. And so we're trying higher doses, 3 days on, 4 days off. The study had been on hold. We found out yesterday from the sponsor that there is 1 spot left to complete national enrollment, and then hopefully we can decide if this is an effective strategy and what the next steps will be. Another trial that is open for uveal melanoma patients that does have a waiting list at the moment is one using a focal adhesion kinase, or FAK inhibitor. FAK has many different roles inside and outside of the tumor and has been identified as a mediator of GNAQ and GNA11 mutations. The FAK inhibitor is also an oral drug. It's taken once daily. And once we identify the maximum tolerated dose, the next part of the study will open to combine it with a MEK inhibitor. There is a waiting list at the moment. There are 10 openings for uveal melanoma patients, 4 of which have been filled, but we would be able to consider putting patients on the remaining 6 slots. This is not an MD Anderson only trial. This is open at a few places in the country, and so we're all competing for those 6 slots, but that does mean it's available more broadly. So in summary, we do have options for uveal melanoma patients right now, including some standard of care liver-directed therapy, standard of care immunotherapy, and, perhaps targeted therapy as standard of care using the MEK inhibitor trametinib. The difficulty there is that it's not technically approved for uveal melanoma with these GNAQ, GNA11 mutations. There are several commercial foundation medicine type reports that will say, oh, you have this GNAQ or GNA11 mutation, consider using a MEK inhibitor. But insurance is certainly within their bounds to say, well, that's not what it's approved for. We don't want to cover it. Typically, your oncologist can help you write an appeal letter that will say, well, we appreciate it's not approved, but there have been studies using it, and there is a small portion of patients that could benefit. And specifically, if you're out of standard of care options, if you've done the liver-directed or immunotherapy, this could be an option outside of a clinical trial. I will say it's not, I wouldn't count on it 100% being approved by insurance, though. The clinical trial options for liver-directed, as I mentioned, are the PV10 study, the immunotherapy porcupine Wnt inhibitor trial with spartalizumab, and of course, the targeted therapy trials I just mentioned. And at the moment, there are some things on hold, really because of the COVID-19 pandemic, and until resources get fully operationalized. The T-cell trials. There is a neoadjuvant trial of nivolumab, an anti-PD-1 Opdivo, with a drug called relatlimab, or LAG-3 inhibitor. And as Dr. Orloff mentioned, we don't typically include a conversation about surgery when we're talking about standard metastatic uveal melanoma treatment. Now, there is potentially the case where you might have that solitary lesion in which, she or I might send you to a surgeon to have that fully removed, in which case you might be a candidate for a neoadjuvant Nivo LAG-3 approach. You would get about 2 to 3 months of this drug. You'd go to surgery, you'd have the standard surgery you were planning to have it removed, and then you'd, on the back end, finish about a year of more infusions. It would be very interesting for us to have some uveal melanoma patients on this study. It's currently on hold, as most adjuvant and neoadjuvant trials are at the moment, but really in our disease type, we certainly know it's hard to find the truly operable patient, and so if you're considered inoperable, then this would not be an option for your melanoma. And as she mentioned, the adjuvant Ipi-Nivo study is currently on hold at MD Anderson. It's not necessarily on hold at all places, so you could check Washington University, University of California, San Francisco, Columbia, and Memorial Sloan Kettering, and Georgetown, and see if it's open there. It's on hold at MD Anderson because there's quite a bit of blood and tumor collection that goes for research. Sorry, what I meant to say is blood and stool collection that goes for research on this trial. And at the moment, our research laboratories are not fully open to collect these things. And so after conversation with the sponsor, we decided rather than skip those, because they are informative and important, we'll actually just hold until we resume operations. The PKC inhibitor trial is also on hold at the moment, really just because the sponsor, I think, is deciding on next steps there. And finally, our upcoming trials, kind of similar to what you're hearing in the field, there's some MAGE trials, so this is a melanoma antigen, also lung cancer antigen and some other types of cancer proteins that can be targeted using either vaccines or T cells or specific drugs. The FAC inhibitor with MEK inhibitor combination will soon to be open, PKC inhibitor with MEK inhibitor also on the horizon, and then potentially PD-1 plus LAG-3, not in the neoadjuvant setting, but perhaps in the metastatic uveal melanoma setting. Finally, I just want to tell you in the context of COVID-19 recovery, as we are all kind of planning what does recovery look like, there's still a few other important considerations at MD Anderson. We still do require quarantine for certain states and certain airports. And so if at screening they identify that you've traveled from one of those states or airports, they will ask you to quarantine inside the state of Texas for 2 weeks. They will send you for COVID-19 testing, and then you'll be able to have your appointments. This is rapidly evolving. It evolves on a daily basis, as you can imagine, and so what's true today on Friday, you know, at the end of May may not be true at the beginning of June. And so our website can give updates, but also, you know, as Dr. Orloff said, just reach out. We're happy to kind of field the calls and find out when we can see you. We are reopening our clinical research portfolio. So we were at a level 1, which was a very limited portfolio. MD Anderson asked each cancer department to go around and identify 10% of their trials that they would keep open. And now, as of last Friday, we have moved into level 2. So this opened us up in melanoma from about 10% of our portfolio to about 80%. And so our PV10 trial reopened, as you saw, the intermittent selumetinib trial reopened. This is essentially trials that have treatments and safety procedures only, but none of these optional research collections such as stool, such as saliva, extra blood collections that go for research, et cetera. That will be level 3 when we fully reopen to 90 to 100% of our trials, and that's anticipated for later this summer. The basic science laboratories are moving into level 2 as of next Tuesday. And so this means a staggered working scenario. So now we're going to have lab people working either about 5 a.m. to 1 p.m. and then the next shift will be about 2 p.m. to 10 p.m. in the laboratories, essentially to help with social distancing in a small laboratory. And then our telemedicine follow-ups, they are allowed for follow-ups. But actually for us in the state of Texas, they are rarely allowed for a new patient. So right now, new patients still have to be in the door face-to-face visits. These are state-by-state rules, of course, and unfortunately, even for follow-ups, I'm not cleared for all 50 states in the state of Texas. We are cleared for certain states, basically, is the bottom line. So still for places like California, we cannot do follow-ups via telemedicine with our patients, and a number of other states. And so it is improving our access, you know, during this time, but it's not quite as ubiquitous coverage as Dr. Orloff has in Pennsylvania. We are also still restricting visitors. So patients do have to enter the building alone, go to their appointments alone, go to their treatments alone, surgeries alone. But the family is able to participate. You know, we're able to participate if the patient calls their family over the phone. If they want to turn on the video camera of their phone, we're happy to engage with them this way. So I would like to thank you all for watching this webinar and give a special thank you to the Melanoma Research Foundation for hosting us.
Thank you both so much. Thank you, Dr. Orloff. Thank you, Dr. Patel. This was a fabulous overview of the current situation. So I know that our patient community will be very appreciative of all of the fabulous content. So thank you both very much.
Pleasure.
For additional information on this topic and other topics, please visit our website at melanoma.org or send us an email at education@melanoma.org. This now concludes our webinar.